All right, everyone. Welcome back. Welcome to the podcast. Bit of a short gap between this and the last episode, which is good. We're trying to launch back into it as sort of short and smaller, little bite-sized ones, so that you guys can, that's sort of the feedback we've been getting. Apologies for the audio quality in the last one. Not sure what happened, but despite Ben's studio level setup over there,
it turns out it doesn't matter what level setup you have. If you don't select that as the input for the computer to record on, it doesn't really matter if you have a nice microphone, is what I learned last week.
Yeah, but anyway, I mean, I'm sure we all managed to sort of, get through it, and hopefully learned a bit about pannus or chronic superficial keratitis, and also, how to turn on a microphone. We all certainly did. What's been new, Ben? I see Ben, actually, if you're watching, he's got some new bling. So the man is wearing a pretty thick chain. This is a new thing since he's moved to the States. I don't know if it would fly as much over here. He's rocking some bling. I think he's been listening to a bit of rap music or something. Is that the case?
Yeah, mate. Guilty as charged. Essentially, see all the cool kids with them, think, why not? I'm 32. I'm as young as I'm ever going to be. I'm just desperately trying to hold on. I've been, I haven't got as far as starting to say 6, 7 or keeping it 100 or whatever else the kids are doing, but I'm just dipping my toes in with the chain. It's a logical place
with the chain. Yeah. Soon it'll be the baggy pants, and yeah.
You're on to me, mate. You're on to me.
All right. So today we're talking about corneal endothelial disease. And I guess we're going to start same way we did sort of last time. I'm going to pester Ben to sort of, I think in this case, instead of launching straight into the disease itself, let's talk about the tissue. So Ben's a bit of an expert on the cornea and the tear film. The guy just loves it. Ben, why don't you run us through at a really superficial level, I guess from superficial to deep, the structures of the cornea in the dog. So, if you're an astute pod listener and perhaps you work with humans or primates, there might be some layers that are different, but we won't worry too much about that. Let's just keep it real simple. So, Ben, what are we looking at when we look at a cornea?
Right. Well, firstly, I'm going to have to start hanging out with you more, because the more I hang out with you, the more alleged experts on fields that I'm definitely not I become. So very, very keen on that. But yeah, so when we're talking corneal anatomy, the outermost layers, the corneal epithelium, its whole job's basically to work as a little armor layer, protect the stroma from naughty things like bacteria and fungi that want to get in and chew it all up. The next layer then in our species is, as Paul alluded to, a bit different in humans and primates, but the next layer for us is the stroma. So most species we deal with don't really have a Bowman's layer, but the stroma is little sheets of collagen and protein stacked on top of each other like little pancakes, and it's mostly acellular. There are little keratinocytes in there, but mostly this is an acellular tissue. And then going down further, we have Decimase membrane, which is the basement membrane of the endothelium. So it's this little elastic layer that is incredibly thin, like a couple thousandths of a millimeter thick, and really elastic material. And then sitting on that as a single cell layer thick is the corneal endothelium, whose whole job basically is to keep the cornea nice and dehydrated. And so they form a single cell layer. We're basically born with a certain amount of them. And I won't touch on what I presume is the next step, but yeah, essentially there's a single cell layer lining at the endothelium.
Yep. Nah, spot on. And one of the funniest things I think I ever heard, and Ben, I think you were at this Zoom meeting when we were talking about pink eye in cattle.
I know where you're going already. Yeah, so good.
This cattle vet got up to talk about the anatomy of the cornea. A very, very Australian fella, I forgot his name. And he goes, right, listen, you got your epithelium, you got your endothelium, and in between you got your stroma. And he's bloody thirsty for a drink. And so that's why those two layers are so important, because I think, thinking back to, my board study, what percentage of the stroma, how much more would it hydrate, when you removed either of those layers. And off the top of my head, I think you remove the epithelium and you're looking at like a 200% increase in thickness from it getting hydrated. And I think the endothelium was something ridiculous, like 500%. It was, I remember it being substantially more. And that just goes to show, how important these structures are. All I would add, and this is, I guess, something I like to use when talking to clients and even and general practitioner vets, is try and think about, and this will play into it later, but try and think about the cornea as skin that's been modified to be clear. And then when we talk about these next disease processes, I think that'll help conceptualize why things go wrong the way they do with the endothelium. Okay. All right. So I guess the next point is, what is corneal endothelium disease? What are the categories of the disease? There's three big ones that I can think of. And then we'll move on to, when we see them, how we treat them, and strategies like that. Do you want to fire away, Ben?
Yeah. So corneal endothelial disease is the big, broad umbrella term touching, as the name indicates, anything going wrong with the endothelium. So as you touched on, Paul, the endothelium's really important, basically, to try and dehydrate that cornea, keep it all really watertight. So if there's any effect with the endothelium from any cause, sort of the symptoms are really similar. But there's a couple of things we can see that I guess that makes us select one process over another. The first would be corneal endothelial dystrophy. So that's dogs who born or essentially are genetically geared towards having faulty corneal endothelium. So we see it really predictably in some breeds. Essentially, the really common ones we see it in are like Boston Terriers, Dalmatians, Basset Hounds, where there's a whole list of others as well. What do you see most commonly clinically, Paul? Any on that list?
In terms of breeds?
Yeah.
I think, as you said, Boston Terriers are probably...
They're the poster child. Yeah.
I think so. And I'm trying to think of what else we see. I think sort of spaniels, like springery sort of spaniels, I tend to see.
Yeah, great point. Yeah, cockers as well.
And I know that there is a predisposition in one of the spaniel breeds that I saw came out of UC Davis, but I forgot specifically which spaniel breed. And but I think clinically Bostons are the big one for like the classic, as you said, the dystrophy.
Yeah. And so essentially, so that's one process. A second process is corneal endothelial degeneration. So as opposed to being genetically geared towards this thing happening and sort of being, set by fate and infinitum that your endothelium is going to expire a little bit early, which is dystrophy. Degeneration's where something's happened to basically make these cells fall away. Most commonly is trauma, like surgical trauma. So for us, a big one is like in cataract surgery, there's all sorts of different methods we use on purpose to try and preserve the corneal endothelium as best that we can. And essentially, if there's any failures of that or the lens doesn't offer for a safe delivery of it without inadvertently damaging the corneal endothelium, then we can certainly damage some of that corneal endothelium and precipitate some of these clinical signs of corneal endothelial disease. You can run into a scenario where the two meet. So you might have a dog that has corneal endothelial dystrophy, also has cataracts, which a lot of these breeds are genetically geared towards getting both. So you can exacerbate a dog already with early endothelial dystrophy and disease, and then add on to that some degeneration, and you exacerbate the clinical signs. It's, although often they sort of work in singular lanes, they can also cross lanes and you have multiple processes of the disease simultaneously. The third that I think of, Paul, and maybe you got another one for me, but corneal endothelitis, so the inflammation of corneal endothelium, pretty recently nicely described, also out of UC Davis. We seem to be shouting those guys out a lot. But essentially, so inflammation inside the eye, so chronic uveitis, then causing a secondary inflammation of the corneal endothelium, seems to be for dogs, where it's been categorized the best, the most likely pathogenesis of it, where, again, with the cells not being healthy, they're not functioning well, we get the same clinical signs.
Yeah. Another recent study that I'm only aware of, because I'll unmask myself as one of the reviewers here, but there was an endothelitis case series that came out of, it was either Korea or Japan, I forget, it's published now. And they saw it at an increased rate in the Shiba Inu, and that's another fantastic paper that's really worth a read. They've got some great images in there, particularly images that are using technology such as optical coherence tomography and OCT, which I always describe to people as kind of like CT for the cells of the eye, kind of. And if you want to learn more about it, that paper's got some cool images. But Ben's, we shout out UC Davis a lot as it is, but for the endothelium, I think, the Thomasy lab over there are just incredible. I mean, they do so much. And
I think that is where I think the endothelitis, I think it's Dr. Myers or Maya. I had the delight of meeting her. She actually toured my work in Las Vegas a few months ago, and she was lovely. Yeah, it was her work, and I think they do have OCT images in that paper too, but I have not read the Korean paper you're referring to, so they might have lovely ones as well. But yeah, terrific.
So clinically, I guess, and they're the categories that I would think about. Clinically, I guess, what do we see when these patients present for the various? There's one clinical sign that I think unifies them all, which is corneal edema. So you got the blue eye, and then we've got to sort of solve from there as to which category it fits in, and that can be challenging. What sort of tools do you use, Ben? Firstly, to identify the corneal edema, and then to sort of put it into one of those subcategories, which is important for treatment, which we'll get to.
Yeah. So essentially, yeah, you're right. The big one's corneal edema. Most commonly, patients present for some descriptor of that: blue eyes, bright eyes, hazy eyes. There's a film on the eye. You name it. That's sort of the descriptor of it. As you know, those of us who might be listening who are not medical background, edema is a word for basically like fluid accumulation of. So the cornea's normally got no fluid in it. Corneal edema now has lots of fluid because the endothelium's not working to keep it thin and dehydrate the cornea in an active process. So other than corneal edema, we start to see other signs of a generally unhappy cornea, basically. So I saw a case the other day with the presenting complaint was outrageous conjunctivitis, quote unquote. It was just the conjunctiva was so hyperemic and inflamed, reacting to this really unhealthy cornea. We can see secondary corneal changes like pigmentation, vascularization. In really end-stage disease, we can see little bullae forming, which are like little blisters forming on the surface. Those blisters can then progress to form ulcers, which are really sore. So sometimes the presenting complaint's this dog with a non-healing ulcer. And they're the common, I guess, things that we can find on a clinical exam. We should say, though, that all these processes can be marked as mild, moderate, severe, and a lot of these changes I'm talking about are only in the severe cases. With the use of a slit lamp, we can really pick up the early cases where we can pick up subtle thickening of the cornea that in health should be about 0.5 millimeter thick. And when you look at lots of corneas, as you do in a residency program, you can sort of eyeball what a normal thickness is. And when you start to pick up subtle increases in thickness, you start to be alerted to the possibility that, hey, there might be something going on with the endothelium. The slit lamp also allows you to get your pipette pipe at a certain angle that you can actually evaluate the posterior contour and the architecture of the posterior cornea and the endothelium. And so, if you start to see thickening or irregularities, you might start to, again, be suspicious. But it's kind of using a combination of findings, not just one finding in isolation. Anything, I guess, more sophisticated than that would be using things like, as you mentioned, Paul, like OCT, or you could use ultrasound biomicroscopy or pachymetry to measure the thickness of the cornea. If you wanted to objectively measure, the thickness, again, knowing what normal values are. Shout out to one of our mentors, Dr. Jeff Smith, who very crudely but very prophetically would digitally compress the cornea. And if the corneal edema worsened with increasing pressure on it, that's probably not normal. The endothelium's not compensating for the increased pressure. So that's something where if it's kind of on the fence and I'm like, man, I think this is a little bit thick, and then you just apply gentle pressure to the eye and you see this pathognomonic corneal edema, you're like, that's not normal. This endothelium is not functioning.
I love the thumb method. I think it works really well. You go above the eyelids, just gentle pressure. They tolerate it well, and you watch it, it gets more intense. And that was one of those little pearls that you probably won't find in a textbook. And yeah, shout out to Jeff. He loves showing people that trick. I think Ben's done such a good job of summarizing it. I really don't have anything else to add to that. I think we've covered all of the tools. I guess now in terms of, okay, we've got the edema, we know the endothelium's the problem. How do we localize into one of those three categories? And I think if you can try and think about dystrophy and degeneration, I don't know that at a general practitioner level, or even sometimes as a specialist level, differentiating the two really matters. But I think the big one that I think the big rule out to me in these cases is the endothelitis. And so what can we do to sort of hone in on that? Because if we treat that, as papers have shown, we can, recover some function and get that edema to clear. And I guess I'll start off and say, when I see endothelitis, it's usually a younger dog. There's usually a distribution on the cornea, which I always get wrong, but it's described in the paper. Is it dorsotemporal or is it ventral?
I thought it was ventral because the thoughts are like all the proteins and chorionic precipitates they're the ones that are. But it sounds like I've only read one of the two papers written on it. So I only have 50% of the available knowledge, but the advent of doing
the same in both papers. I'm just bad with this.
Yeah, I think it's ventral, but you keep talking and I'll pull it up.
Okay. The other thing is the history, as I said before, young dog, but Ben famously saw a case that I don't think he remembers, or maybe he does, where he asked the owner, has your dog had any trauma recently? The owner said no. And then when Ben was going to give the dog an injection or something, he was like, oh, is he okay? And the owner said, nah, mate, don't worry. He's as tough as nails. He got hit in the head by a car the other week.
You can't make this stuff up, honestly.
You can't. Everyone's probably thinking, what are they doing down there in Australia? And the answer is probably...
So I was close on the name. My apologies to Dr. Mays, not Dr. Myers. Dr. Melanie Mays published the paper out of UC Davis in 2021. And yeah, the ventral cornea, most extreme for the involvement.
I probably, yeah. I don't know. I always, that's not very confidence inspiring for my clients who are listening. Anyway, so those are the two big things for me. Is there any other signs of uveitis? I will say one thing, and it's a bit of a pet peeve of mine when I see other people, in particular with diffuse corneal edema, try and grade flare to a very precise manner, like trace flare. And I'm always on our residents about this. Like if they come to me with marked corneal edema and then they try and tell me that the dog's got trace flare, I just don't actually believe it's physically possible to see that with the edema. I don't know if you disagree with me, Ben. So looking for flare can be challenging in these cases. To look for uveitis or other signs, I would say in the endotheliitis cases, at least you got the benefit of, usually, as we just said, it's going to be in one location. So go to the non-edematous area in order to assess for flare. Yeah. I tend to find, our degeneration cases and dystrophy cases, the ones that I've seen, I often find it's diffuse.
Yeah, absolutely.
In my experience,
I think the dystrophy cases early, like you're right. When severe, absolutely diffuse. starting, it's typically like dorsal and works its way down. But by the time it's severe and it's like, oh my goodness, this dog's presented for bright blue eyes, I agree. Yeah, diffuse all through it.
And so treating these endotheliitis cases, I think that May's paper is a really good one. They talk about the use of topical anti-inflammatories. And, that's what you've got to do. There are also a new class of drugs that we'll talk a little bit about, and there's a study that's come out even for degeneration. Historically, we thought these cells don't regenerate. However, now there is a new class of drug called Rose kinase inhibitors, and again, UC Davis has done some work with this, and they found that you can actually regenerate these cells to some capacity, and it works better in the mild to moderate cases, which makes sense because there's more cells there to regenerate. Okay.
Yeah.
Whereas, in those really advanced cases, it can be really challenging.
And the frustrating thing with that is, oh no, mate, that's perfect. I mean, the frustrating thing is by the time owners are knocking on your door, unfortunately, often the disease is really severe. And, I can understand fully, a lot of people think cloudy eyes is a normal aging change in dogs, which a cause of cloudy eyes being nuclear sclerosis, maybe. And so often this is sort of sat on and doesn't arrive to us until it's quite advanced. But yeah, it'd be a wonderful, wonderful drug class to have available into the future for us. Yeah. The only thing I'd add, you're right, the use of topical anti-inflammatories for endothelitis, that client that you mentioned earlier, I do remember very clearly. This little puppy dog would have been 6 months old, had severe bilateral corneal edema, had flare that I could see. I wouldn't have called it trace, but I could see flare in both eyes. And I think he had choretic precipitates too. So I was like really confident that, hey, there's some pretty significant inflammation inside these eyes. I think for him, like topical anti-inflammatories, subconjunctival triamcinolone, and I'd probably even send him home on oral steroids or oral non-steroidals as well. Really threw the whole kitchen sink at the dog, and he did so well. Like, the owner was completely nonplussed. Like the dog came back with pretty normal looking eyes. I was like, oh my God, mate, this is incredible. Like, I can't believe how good it is. Like, I gave the drop stock. So like, of course. So I'm like, no, you don't understand. Like, this is incredible. But yeah, the endothelitis cases can do really well, and especially in young dogs that they most often affect. Whereas, the other causes are more of a chronic management thing, which it sounds like we're transitioning to talk about.
Yeah. So we've got. We'll wrap up with a couple more. With treatments for the couple more diseases, only because I've got about 5 minutes, so I got to get into consults. So now let's talk about treatments, I guess, for the endothelial degeneration / dystrophy side of things. Where are we at with that? What are the challenges? I will add one thing that I think I wanted to expand a little bit more about at some point. I don't really know where it sort of slots, but the formation of those little blisters that rupture and form ulcers. Those ulcers can be quite challenging to treat, and we'll talk. Let's sort of package that in this section here. Like, how do we deal with those ulcers? How do we deal with the degeneration? What options are available to clients and vets? Yeah.
So essentially, in an ideal world, this has been published from where Paul and I both did our residency. I think 10 years ago now. So it's been out a while. But it's also it's one of the standards of care for humans as well, or one of the big pillars of treatment. Prospects of like types of corneal transplants or partial thickness corneal transplants, where basically if these cells are not working, we can ideally replace them with the cells of a young, healthy animal. For lots of reasons, it's not the most practical thing to achieve for the vast, vast, vast majority of ophthalmologists around the world. Principally, availability of donor tissue and how hard that is to get viable tissue, store viable tissue, ensure it's viable, use it in date, all those sort of things. So although ideally, that's amazing, and it's out there, it's not something that's offered really at all, or not very commonly in only a few places around the world. So I'll start with that caveat. essentially, for mild to moderate cases, the goal's better to keep the eyes comfortable and prevent those little blisters forming. And so for me, I usually just send them home with a topical sodium chloride solution to try and pull some of that fluid out the front of the eye. It's not a miracle sort of drug. It's not going to halve the corneal thickness or appreciably decrease the clouding. The idea is just if those little water-filled pockets form, we can sort of squeeze the water out of them just by applying some salt. So essentially, it's a pretty non-sophisticated treatment, but the goal is really just comfort. For the really advanced cases where, say, we get these ulcers, so they pop, we get these ulcers, the cornea is way too thick and really unhealthy, and the normal healing process just does not work, which unfortunately is commonly the case. If we start to get recurrent ulcers, and no matter what meds we're giving, they're not healing or they just keep coming back, then using surgical techniques to try and thin out the corneas is certainly where I lean to, Paul. And so like a Gunderson graft or a superficial keratectomy and hood advancement flap, I think is the other cool acronym we like to give these things, the SCAF. I think it works really well, but the goal's not to drastically improve vision or anything like that. In some cases, I think anecdotally, maybe it does a little, but that's not really the goal. The goal's just to keep the eyes comfortable when you got these, pretty profoundly sore eyes that we can't make comfortable with meds. Is anything you'd add on that?
No, I completely agree. And I guess I would end on my last little tidbit with the Gunderson graph or the SCAF. If I can, this hood, that one.
Let's go, skitty bap.
Never ever promise a client improvement of vision following that, because you'll just disappoint them.
and never spend 30 minutes telling them you're going to bring the conjunctiva from the top and the bottom of the eye, to then have someone else do the surgery and bring the conjunctiva down the middle, and as a resident have to explain why that happened.
The grand reveal post-surgery task. Yes.
A few inside jokes, but very silly.
Yes. We can't say too much more. But no, I think management of expectation in these cases is huge, as Ben sort of alluded to or outright said. In humans, we'd be doing a corneal transplant. Or some sort of therapy like that, some sort of surgical therapy. The situation in dogs is just that's really hard to achieve for a number of reasons that Ben's really well, really nicely outlined, and so we're left with these sort of salvage procedures. And just always if a client is wanting to do that procedure in order to improve vision, I won't do it, because I'm like, listen, no, this is a procedure to stop ulcers, and if we get some vision back, great. Or if we get some improvement in vision, great. But often it's temporary as well. There's a nice paper, again, I think it was out of UC Davis by Taimi Horikawa, that looked at the rate at which the cornea is thickened back up after a Gunderson graft. And I can't remember the specific numbers, but after 12 months, you're kind of back to square one.
Yeah, that's a nice summary.
Yeah. Awesome. All right, well, thanks everyone. Sorry I have to sort of jet, but it was a pleasure as always, and we'll see you guys next week.
Thanks, Paulie. Catch you, mate.
Yeah.